Hello, my name is Dr. Dave Webster, and this is part of my ongoing video blog series about the travesty of lack of access to PET-CT in Ontario. This particular video blog is entitled Another Deliberate Casualty of Our So-Called, quotes, Quality Healthcare in Ontario, and this is courtesy of the 4 PCs and, of course, Cancer Care Ontario. This is the story of a 63-year-old female with multiple nodules with the misfortune of living in Ontario and not Quebec. She's a smoker, and for some reason she has a chest CT in February of 2018, and it shows a 3-centimeter spiculated nodule. That means it's quite spiky, as you see around the edges. They're a little more likely to have cancer, but because she lives in Ontario, she can only be followed up by the CTs, and so in July she has another CT. And there's a little change here, as you can see, based on changes elsewhere. They decided she needs further investigation, but remember, this is Ontario, so they have to do the biopsy first. The big question in this woman is, which nodule should they biopsy? We do have this one, of course, but then there's also nodules here. There's some abnormalities up here. And as you can see, she has multiple nodules elsewhere in both lungs. She has about 8 nodules, right? So which one would you biopsy? Now remember, Ontario is the only medical jurisdiction on the planet, possibly in the universe, where you have to have a biopsy of one of these lung nodules, a high risk in this patient, particularly being a smoker, before she could have a PET scan. So the question is, which they biopsy? They decide to biopsy this one. So she has this 15 centimeter needle stuck in this mass here in the left lung on August of 2018. But, as is not uncommon, the biopsy actually comes back negative. Now, to explain this again, this is an 83-year-old woman who, here we have the CT fused with the PET. Now, she had the biopsy before she could have the PET scan, but when we were able to do it later, we were able to show that the needle was in scar tissue. This was the only active part. If they had put the needle there, they might have got a positive biopsy. But in the meantime, the patient had to go in the ICU because her lung collapsed. She's got chest tubes in and so on. A very nasty situation. Only by using FDG PET CT can you show where the most likely spot to get a positive biopsy, even if you have to just do it in the chest. But in addition, for this poor woman, it turns out that it also showed that she already had spread of cancer to 2 little lymph nodes above her right clavicle, which were not identified on the CT. And we quite literally could have biopsied that on our kitchen table with an ultrasound with absolutely no risk to the patient, absolute minimal stress, and in the least amount of time, and had the answer. But here's my poor woman. It's March 2019, more than a year after she's had the first indications of having nodules, and they have no tissue diagnosis, and everyone assumes she has cancer, but especially the patient. You can imagine how she feels. However, she's getting quite a bit sicker. She ends up with acute shortness of breath, comes into the emergency department, and what she probably has is a pulmonary embolism, or a blood clot, which has moved from her lower extremities into her lungs, and that's a dangerous situation. And people who have cancer are more likely to get these. However, now she is so sick and short of breath, she could not possibly have another lung biopsy. I actually witnessed her. She was in the department. We were trying to do some tests on her, and she was just desperate for air. She couldn't lie down flat, and so on. Now, it's also highly likely that she probably does have cancer, almost certainly, and it probably is spread somewhere else, like in that 83-year-old woman. And but the PET scan, of course, would be able to show if there was a safer site to biopsy, and probably would have potentially more than a year, or last August, for example, or more than a year ago. So, the impact on lack of access to modern imaging technology for Ontario patients. Cancer Care Ontario enforces standards of care that are exact opposite of the entire world expert body of opinion. This woman is just yet another example of the consequences for our patients. Yet, if I were to ask her oncologist to defend how they've used imaging to manage her case, as has already happened to me, I would risk being accused of acting beyond my scope of practice. And I am an imaging specialist, imagine, and having the nerve to ask them a question about her imaging management. But I could be reporting to the chief of staff for acting outside my scope of practice. What about the rest of the world? Quebec and Paraguay, forget about the differences in who would qualify for health care. Whenever you identify a chest nodule of this size, whatever way you did it, the physicians would know the next test needs to be an FDG PET CT scan. And as you can see, this is the most likely to give you the most likely positive cancer. Even if you do have to do the biopsy in the lung, it'll tell you where to put the needle. And as we've seen, maybe a safer, more accessible site to biopsy. But most importantly, from the patient stress point of view, they literally, if it turned out to be a cancer, could be on therapy in 6 to 8 weeks. So both, it's not good to have cancer, but at least they know they're on treatment quickly. However, for our Ontario patients, it's now been 13 months and no diagnosis, and we have a very sick woman who is very likely to die. So in summary, I'd like you to think about how it would feel if you were this patient and living in Ontario and knowing that this is being done to you deliberately. So again, maybe you're beginning to understand more fully why I have said if you have a lung nodule or cancer or any other serious diseases where PET is the accepted standard of imaging management and you want access to 2019 levels of medical care, you really have no choice except to leave Ontario. So let's go back and look at Cancer Care Ontario. We're told they're a world-class cancer care agency. CCO, our future healthcare built with care. What I can tell you is that 100% of what happened to this woman and hundreds of like her on a daily basis in Ontario is due to the deliberate actions of Cancer Care Ontario, who, remember, was long ago told to discredit, delay, and block Ontario patients from PET. And again, remember that it isn't just PET that Cancer Care Ontario deals with. This is how healthcare decisions are made in Ontario. Now, am I suggesting it's the goal of these people to deliberately increase the stress, risk, pain, management, for these patients, make life miserable for them and maybe death earlier? No, I'm not saying that. On the other hand, are they 100% aware that because of their efforts, this is what happens to patients on a daily basis? Absolutely. However, that's not their concern. Their job is to carry out the agenda of carrying out the mandate of those who make critical healthcare policies for you. Currently, it's the Ford government, Ms. Elliott, and as the Minister of Health, and of course, Dr. Ruben Devlin, who's in charge of quality of care in Ontario. Now, of course, if you don't already know, the only way this could possibly have happened over all these years and continue to happen is if our professional journalists do their job to make sure that they carry out this agenda by making sure you do not have access to this information. I mean, think about it. What self-respecting professional journalist would think that Cancer Care Ontario performing unethical and immoral experiments on cancer care or cancer patients was worthy of investigating or reporting? And thus the absolute critical need to go on social media, on my sites and so on, get this information out to people. Otherwise, nothing is going to change. And one day it may be you or someone you care for that is yet again another casualty that is directly because of the action of the Ontario government's medical experts. Thanks for listening.